Hello, I'm Dr. Michael Graham, and today we're going to be talking about first MPJ pathology, and more specifically, we're going to talk about the pathodynamics of Metatarsus Primus Varus and Hallux Abducto Valgus, more commonly known as bunions. But I like to get more specific as to what the actual deformities are versus just a generic name for things. And because a bunion doesn't really tell us what's wrong. That tells us the symptom, not the underlying etiology. And for most physicians, what we want to do is to get to the root cause and have our treatments focus there versus just treating symptoms. Because if you only focus your attention on treating symptoms without eliminating or reducing the underlying cause, then those symptoms are just going to keep reoccurring. There have been so many lectures given on bunion discussions, but the problem is with every of the other lectures is that they only get into basically the surgery of it. They don't get into the underlying pathomechanics, and so that's what we're going to dive into right here. So let's get started. Now, we know that somebody that comes in with this bunion deformity, that there is some kind of a pre-existing weak link. And so when we take a look at this standard dorsal plantar x-ray, a DP x-ray, we see that this patient has a moderate bunion deformity. And so we want to think about what is the pre-existing weak link. Why did the patient get this? Because not everybody ends up with this deformity. So we know that there's an angular deviation between the first metatarsal bone and the hallux. So is that the weak link? Is that where our focus should be driven with our treatment options? Is what can we do to realign that first MPJ? But we need to take a closer look, or not a closer look, but zoom out a little bit and look at other parts of the foot to see, does it really make sense that that's where we should focus our treatment, just with some kind of surgery to realign the head of the first metatarsal and the base of the proximal phalanx? Well, when we look at the entire medial column over here, or at least pull back a little bit to the base of the first metatarsal bone, there is a pre-existing weakness that happens at the first medial cuneiform joint. This is where there's supposed to be a lot of stability, but rather than that being stable, it's unstable. So whenever we have a foundation issue, that's where we need to start our treatment. So what happens with Metatarsus Primus Varus is that there is instability at the first metatarsal cuneiform joint. It's just like the Leaning Tower of Pisa. The foundation is bad. The metatarsal bones themselves are absolutely perfectly straight. The least amount of stability of the first metatarsal bone is distally at the first MPJ. So our focus needs to come back here to the base of the first metatarsal. So again, what are we looking at with this deformity? Well, we see that the first metatarsal bone has shifted medially, and there's usually a dorsal aspect of that too, dorsal medially, and we have an increase in the intermetatarsal angle because of this instability at the first metatarsal cuneiform joint. This is a Metatarsus Primus Varus. Because of that, then we see that the hallux abducts, laterally deviates, because of the Metatarsus Primus Varus. So this is for every action, there's a reaction, right? So this is the reaction to that. So we have all these forces that are pushing the hallux laterally. And then we have this progressive dynamic imbalance of forces acting from the hallux, pushing back, redirected from distal to proximal from the 7 muscles that act on the first MPJ, that is contributing to the increased deformity and the increased intermetatarsal angle. And again, all of this happens and it starts back here at the base of the first met cuneiform joint. So is that it? is that all that we need to take into consideration? And do you think that there's any other factors outside of the first ray that we need to think about? Well, you know, if we just did a Lapidus procedure then, or first metatarsal cuneiform joint arthrodesis, then that should be the end of the story, but we know that that's not the case. So the reason why we need to take special care and attention to patients with this deformity is because it gets progressively worse. And just like with any disease process, the sooner that we can provide a real treatment, then that can help to delay more aggressive surgery later on. And so, you know, somebody that has this more mild deformity, if they live long enough, you know, 84 years later, so this is a granddaughter and a grandmother, this is a situation that this patient could potentially be dealing with and have to suffer and have this physical deformity and have shoe gear irritations and just the embarrassment of having this gross forefoot. So this is we need to think about this as a dynamic, not a static deformity. Okay, so there is excessive motion occurring within the first MPJ and the first metcuneiform joint, and that's why this gets worse. And that's where most of us just think about this as a static disorder. We take a look at that x-ray and say, well, all we need to do is just take this perfectly straight metatarsal bone, cut it and shift it, and now we fix the problem. But what is the #1 complication of bunion surgery? It's recurrence, and the patients are not happy. So what are the options that we have to try to treat this? Well, of course, we think that we want to try something non-surgical, and we look at these different braces and sleeves that are placed over the bunion to try to give it some protection. But this is not a real treatment. You cannot wear these things in your shoes, and there's no evidence to show that this can reverse, delay, or slow down the formation of a bunion. So when we look at those, it's a ridiculous option. So then we go into more than 100 surgical procedures that have been described to fix bunion surgery. And the reason why we have so many different surgeries is because none of them work. They all have associated complications. And we just, again, think about taking this perfectly straight metatarsal bone, we cut the neck, shift it over, and we think we fixed it. And again, you can skin this cat so many different ways, but all of these have potential risks and complications. And the biggest problem is that the underlying deformity has been missed. So all of these are just more almost cosmetic procedures than a real orthopedic fix, looking at this the dynamic problem. So we take a look at this typical bunion procedure here that I think that the majority of surgeons, if they were surveyed, would say this is an excellent result. But no, that's to the uninformed. To you, the informed, we know that we have not fixed the underlying cause. We still have instability at the first metatarsal cuneiform joint. Even worse is that by performing this procedure, we have shortened the first metatarsal bone, and now we've created a pathologic parabola of the metatarsal angle here. So the first metatarsal has been significantly shortened. So now this patient has developed pain under their second MPJ. And that's why a lot of people too, they get that pre-dislocation syndrome just because of the irritation under the second metatarsal bone. So we see about that significant shortening. So this significantly affects the first MPJ. So is that really a true corrective procedure? No, it's a cosmetic procedure. We haven't fixed the underlying cause. So what is the treatment philosophy for orthopedic procedures? Well, it always goes back to 3 simple rules. That which is unstable, make stable. That which is crooked, make straight. And we want to use a joint preservation over joint destructive procedure when possible. And of course, we don't want to just have a temporary procedure where we know that the deformity is just going to reoccur. That does not give any benefits to our patient. So let's take a look at this x-ray here. This patient comes in for a bunion consultation, Hallux valgus. They have pain and they want to know, what can you do to make this go away or prevent it from getting any worse? So instead of just limiting our attention to only the first ray and the first cuneiform joint, we as ethical and well-trained surgeons are going to know that the entire foot structure must be taken into consideration. So don't just limit your focus to the first MPJ. We need to always start looking at the hind foot, at the alignment and the position of the talus on the calcaneus and the hind foot. And what do we see? Immediately we see that there is a partial dislocation of the talus on the calcaneus. Okay, this is a recurrent talotarsal joint dislocation, a subluxation, whatever you want to call it. This is a pathologic deformity that has severe and major consequences to the structures of the medial column of the foot, specifically onto the first metatarsal bone. And that's what the rest of this presentation is going to really look at. So we have more than just this one deformity here, and we know, and it's been documented in almost every scientific paper published on Hallux, Valgus, and Metatarsus, Primus, Varus surgery, that the underlying etiologic factor is a hyperpronating or a faulty foot structure back here between the talus and the calcaneus. There is an unnatural, excessive unlocking of the joints of the medial column of the foot with excessive forces acting on the medial column. And so it's the combination of an unlocked and excessive forces that are pushing up on that first cuneiform joint and the first metatarsal bone, the head of the first metatarsal during the gait cycle, that makes this a progressive deformity, not a static deformity. This is not about flat feet either. This is about a faulty foot, subtalar joint instability. So we see that this might not look significant, but it is significant. When the patient's hind foot goes from rectus into just excessively turning in, you can see the negative effects that happens to the hallux and the first metatarsal. So with every step that this patient takes thousands of times a day, she gets irritation to the dorsal medial aspect of the first metatarsal head. And so this is the whole trickle down effect because of a unstable talotarsal joint. So the number one deformity that we have of why somebody gets a bunion, it all starts because they have an instability at the first cuneiform joint. So you have to have that. If you don't have that, then the patients could then end up with hallux limitus, or just that trauma to the first metatarsal head, but with a straight metatarsal bone. So the only way that the first metatarsal bone is going to deviate medially is because of the weakness of the first cuneiform joint. So we have the talus that is abnormally aligned. It's partially dislocated on the calcaneus, and then that causes this trickle down effect that leads to the excessive forces and misalignment at the first metatarsal phalangeal joint. And then the tissue, the periosteum, is being pulled on the dorsal medial head of the first metatarsal, and then that's why you end up with the bump. So and you can ask questions too, and then at the end I'm going to go back and we can address those, but I'm just going to keep the flow going here. So so here we take a look at the lateral, and it's the same thing. So we have instability at the first cuneiform joint, but then we add in this very strong and major factor of this partial dislocation of the talus on the calcaneus. So the talus is pushing forward, unlocking joints of the medial column of foot bones, and then add in the ground reactive force that pushes that first metatarsal bone up and out. And then we have the distal to proximal forces acting on the first metatarsal head. So that's why the first metatarsal bone has nowhere to go except up and out. So I think that makes a lot of sense. So now we've put together this entire picture. Now, if somebody is non-weight bearing, then they're not going to have any of those excessive forces acting on the first metatarsal bone, but this is a weight bearing deformity. So the more that the patient stands, walks, or runs, that's going to be more that those forces are pushing up on that first metatarsal bone, and that's why this is a progressive deformity. So we have on the left here this just regular x-ray, and this is what we usually base our surgical recommendations or treatment options on. But this is a weight-bearing fluoroscopy of the same patient. So you can see that the difference between where the metatarsal bone, the head of the metatarsal bone is aligned under the sesamoids is when the talus is aligned on the calcaneus. So the patient is putting their hind foot from a neutral, where the talus is aligned on the calcaneus, into relaxed stance position where the talus is partially dislocating on the calcaneus, and that's why that first metatarsal bone is being pushed distal medially. And then you can see the reaction of the hallux is going to react to the motion from the first metatarsal bone. It's not that the hallux is turning in, and I mean, there is going to be that other secondary force, again, from the tendons pulling from distal to proximal onto the lateral end of the first metatarsal bone. So now it makes a lot of sense of why we get a recurrence of a bunion deformity after we've gone through and we did this great straightening. We've reduced the angular deformity. The intermetatarsal angle was reduced during surgery. We were very happy with that, except that then here a couple of years later, the patient's not happy and they see that their bunion's coming back. And that's because we never addressed the underlying etiology. So we focused our attention only on the first metatarsal bone, and even the hallux, we can do that Aiken, whatever, to straighten that, but we still have these same pathologic hindfoot forces that are acting on the first metatarsal bone, pushing it out of alignment. Here's the again, just another view of this, looking at the lateral. So we have the unlocking of the medial column of foot bones. So we have to take that into consideration because we need to solve both parts of the broken foot structure that we have here to follow those orthopedic principles. Here's other patients, and this is something that surgeons tell me all the time. They're like, I've never had a patient come back to me with a recurrence. Well, that's because they went to somebody else. And how do you know that? Well, you've probably had patients that came to you that had a bunion surgery from somebody else, or the patients just completely give up. But if you just looked at this under an x-ray, you'd be pretty happy. But usually when you take x-rays of patients' feet, they're standing on both feet, and so they don't have the full effect of that partial dislocation of the talus on the calcaneus. So you can now multiply these excessive forces 8,000 times a day over millions of times over a couple of years, and that's why we get the recurrence of the deformity. So we haven't really fixed the entire foot structural problem. So we know that the major deforming force that causes metatarsus, Primus, Varus, and Hallux abducto valgus begins with this hyperpronating foot, this partially dislocating talus. And you can see that this does not have anything to do with flat feet. The calcaneal inclination angle is normal in this patient, but we have this partial dislocation of the talus on the calcaneus, leading to that trickle-down effect of the excessive motions. So usually, what is the gold standard for somebody that comes in with that bunion procedure? Well, we say that we're going to give you these custom-made foot orthoses. This is going to then take away the deforming force. This is going to be the savior of this foot deformity. This is going to prevent it from getting worse, or after surgery, it's going to prevent it from coming back. The only problem with that is that there's absolutely no literature to support those claims. Actually, the literature says the opposite. The literature tells us there's a study for 1-year follow-up of women who had bunion Hallux valgus deformities, and what it showed is that after a year that a foot orthotics did nothing, had no effect whatsoever from the deformity going from mild to moderate. And again, they say that we need to effectively treat the subtalar joint hyperpronation, which is the partial dislocation of the talus on the calcaneus. That's why we have hyperpronation back there. So again, looking at the effectiveness of a foot orthotic is laughable. It's actually almost a crime because we're giving patients, telling them that this is going to help them, but the literature does not support that. So here's another study from back in 2004 with a randomized study looking at the effectiveness of orthosis to prevent the Hallux valgus deformity from getting worse. And of course, it said that there was no improvement whatsoever. And that's because the talus is still partially dislocating on top of the foot orthotic and pushing that metatarsal bone out of place. And so, you know, again, there's a lot of places that orthotics can help, but the literature tells us that it doesn't help here. Here's another study looking at juvenile bunion deformities. And again, it showed that after these kids of using a foot orthosis, that their feet continued to get worse. It didn't get better. So we have literature supporting that these devices do not work, and there's not a single paper published that shows that prevention or slowing of the progression of the deformity. It just doesn't make any sense. Here's another study from 2003. It again says that there is no difference with or without the orthosis. So again, why does an orthotic not work? And again, they're good for certain things. Don't get me wrong. I mean, I think that if you wear shoes, you should have an insert in your shoe, but we have to think about, you know, truly the effectiveness. And when somebody's walking, an orthotic cannot prevent the partial dislocation of the talus on the calcaneus. It cannot stop that subtalar joint hyperpronation. So we still have those same excessive forces pushing that metatarsal bone out of alignment. So that brings us back to extraosseous talotarsal stabilization. And this is an effective form of treatment when it comes to the stabilization and realignment of the subtalar joint, of the talotarsal joint. So EOTTS was compared to custom-made orthotics, foot orthosis, and this is a multi-center study that was published in the Journal of Minimally Invasive Orthopedics in January of 2015. And what they found is, with this radiographic measurements, is that an orthosis had about a 3% positive angular change, versus the use of HyProCure, which had almost a 60% improvement in the radiographic angles. And that 3% was within the standard of deviation. So pretty much there was null effect. There was no change whatsoever. Same thing with the sagittal plane. There's basically no correction with the foot orthosis, but yet we had almost a 30% improvement and the talar angular angle with EOTTS. So now we have science to support that HyProCure with extraosseous talotarsal stabilization is a far superior option when it comes to stabilizing and realigning the subtalar joint. And it just makes perfect sense. So let's go back to the scenario and why this is so important. And this is a case study that a surgeon submitted to me. A patient underwent a Lapidus procedure, and within a year, she came back with the same pre-op complaints of why she had the bunion procedure corrected in the first place. The surgeon said, okay, well, we know that there's instability at the first metcuneiform joint, so I'm going to perform a Lapidus. And he did, but we can see that we have an issue here. So we have a comparison of the patient standing in relaxed stance position on the right and neutral stance position on the left. So with neutral stance, we see that the talus is realigned on the calcaneus. And with relaxed stance, we see that there's that partial dislocation in the medial and anterior deviation of the talus on the hindfoot. So that's pushing that first metatarsal bone out of place still. And then take a look at the fibular sesamoid, how when the talus is aligned on the calcaneus, that the fibular sesamoid is normal sesamoid position, but then look what happens when the talus partially dislocates on the calcaneus. We see that the first metatarsal bone is still medially deviating, and we have a laterally peaking sesamoid. It's actually the sesamoids don't move. It's the first metatarsal bone that moves. Now, the other thing that I always just cringe at is when we perform a Lapidus procedure, we always are going to shorten the first metatarsal bone because we have to remove the articular cartilage. So you're going to get at least a centimeter, if not more, of shortening of the first metatarsal. So now she had this procedure. She has pain in her first MPJ, and now she's developed metatarsalgia on under the second MPJ. So now let's put this foot into action. And as the patient goes from the swing phase to full weight bearing, that's where we're getting this pathodynamic deformity. Okay, so think this is that we're putting this foot into motion and thinking about how that first metatarsal bone is being pushed out of alignment 8,000 times a day with every single step that she takes. So it's no wonder why she develops the metatarsalgia and recurrence of pain in her big toe joint. Let's take a look at the lateral x-ray now. Very significant. Again, usually we're only looking at the forefoot, but now that your eyes have been open to this, you see that we have a significant sagittal plane deformity, how that talus has fallen anteromedially, obliteration of the sinus tarsi. The subtalar joints are no longer in constant congruent contact. We have a partially dislocating talus. Because of that, and this is also, very obvious looking at the medial screw, how it goes from a kind of horizontal position when the talus is realigned on the calcaneus to a more oblique or vertical alignment because the navicular has fallen down, because the talus has forced the navicular out of place, and we're getting still this instability to the medial column of foot bones. Okay, so all of that begins because the talus is partially dislocating off of the calcaneus. Now, the original surgeon, he again was trying to do his best, and he understood that, well, this patient has a misaligned hindfoot, but rather than simply inserting HyProCure into the sinus tarsi to realign the hindfoot, he performed a medial calcaneal osteotomy. So this patient had a medial calcaneal slide, she had the screw put in, then she had the lapidus, she had pain from the head of the screw, so the screw was removed, and after all of that, she still ended up with more pain in the ball of her foot and around the inner bunion deformity. So to us now, it's very obvious why all of this pain is occurring, because she has this partially dislocating hindfoot, this subtalar joint hyperpronation. And I don't care what kind of a foot orthosis you put into this patient's shoe, it will be incapable of stabilizing and maintaining the alignment of the talus on the calcaneus, preventing the navicular from dropping and creating all of these excessive pathologic forces on the medial column of the foot. So thank goodness the patient ended up at a surgeon that performs HyProCure. So the surgeon popped in the HyProCure, and immediately the patient felt a significant improvement with the whole forefoot pain. Not only did this help her foot pain, but we know that the subtalar joint here is the foundation joint of the body. So this patient was also experiencing hip pain and back pain. So after HyProCure was placed into her foot and the talus was realigned on the calcaneus, her hip pain and back pain also resolved. So that's why when it's so important to realign and stabilize the talus on the calcaneus, because it negatively affects the foot and ankle structures, but it also affects proximal structures as well. So here we can see this is just full weight bearing. These are not altered in any way. She's just standing on her foot, and somebody else took these x-rays. I didn't have anything to do with it. You can see how we have reduced the inner metatarsal angle, and we've realigned the first metatarsal bone back over the sesamoids. So it could have been possible that all of this patient needed, instead of having a lapidus and a medial calcaneal slide and a removal of the screw from her calcaneus, was to simply have a HyProCure put into her foot to treat the underlying etiology of her first-rate disease, and maybe this secondary pathology would resolve on its own. So it's something to consider because, again, we're treating the underlying etiologic factor of Metatarsus, Primus, Varus, and Hallux, Abducto, Valgus. So now when these children have juvenile HAV, and we take a look at the x-rays, we see how the talus is not aligned on the calcaneus, and we have, and there's just, again, no way, how could you even consider prescribing a foot orthotic for this patient and really, to sleep at night, knowing that you've done justice to this patient. You haven't. It's a subtherapeutic form of treatment. It should be malpractice to tell somebody that we are giving you, by this $800 pair of orthotics, that we're going to prevent your bunions from getting worse. The literature does not agree with you. But we do have another form of treatment, extraosseous talotarsal stabilization with HyProCure, that is proven to address the underlying etiology without doing any harm. This does not cause arthritis. This only helps the patient. Yes, occasionally we have a patient that doesn't tolerate the correction and you have to have a removal, but the device is easily removed, and we have not had anybody that had long-term complications because of having their hind foot realigned. Okay, so let's think about this. So here we have this pediatric patient who is taking 8,000 steps a day, and with every step, the talus is partially dislocating on the calcaneus, creating the instability at the first cuneiform joint, and then we have all of these pathologic forces acting on the dorsal medial aspect of the first metatarsal head. And then think about, as they aged 40 years of age, they've taken over 70 million steps. So of course, this is only going to get worse. It'll never get better. So here's the lateral view. And again, I've tried to take these weight-bearing fluoros and match them up to put it all together. But you can see the effects of that talus going from a aligned position on the calcaneus to partially dislocating and pushing that first metatarsal bone out of alignment. And again, think about the unlocking of the first cuneiform joint and then the ground reactive force pushing up on the first metatarsal head distally. So now we could actually suggest to the parents and to the child that instead of just letting this progressively get worse, which is guaranteed that if we don't give them any form of treatment, it'll progressively get worse. And not only are we going to have the negative effects to their forefoot, it's all of the negative effects of the recurrent talotarsal joint dislocation to their knees, hips, and back. So this is a pre and post insertion of HyProCure. So we can see the before, how the first metatarsal bone is being forced away from the sesamoids, away from the second metatarsal bone. And this is post-op, how we've significantly reduced that. So you might think it's hocus pocus, but here we go. So this is the before and after. So you can see here's the HyProCure, and it prevents the talus from going dorsal medially, and so it slows that force pushing up on the first metatarsal. So this is an effective form of treatment versus doing nothing. So there's some rules that I want to talk about when it comes to performing HyProCure along with first MPJ disease. So here we can see before and after, where we've stabilized the talus and the calcaneus. And then we take a look at what is the effect on the first MPJ. Now, some patients have minimal to no improvement because it all depends on the flexibility and reducibility of the first cuneiform joint and how severe of a deformity we have of the first metatarsus primus varus. So with this one, we stabilize the hind foot, and that should at least help to slow some progression, but this patient probably also needs a secondary surgery. Now, we recommend that you always perform the hind foot stabilization prior to performing the first ray procedure, and you should, when possible, it's not always possible, when possible, you perform these as a staged procedure. You first put in HyProCure, and then you allow the patient to heal from that, or at least significant, they might not be 100% healed before you go in and then perform the first ray surgery. I'm going to tell you why in a little bit. But we have other situations like this patient who we have the before and after. HyProCure has been placed into the sinus tarsi. We see a significant reduction in the medial dislocation of the talus. And what was the effect on the first ray? Well, we brought this patient back into a mild bunion to no, mild metatarsus primus varus to none. I mean, this is absolutely a complete reversal of the metatarsus primus varus without performing any surgery of the first MPJ. So we were able to actually fix this patient's forefoot without doing any surgery at their first MPJ with a 10-minute procedure of inserting HyProCure back into their sinus tarsi. Something that I do want to bring to your attention is you can see the shadow. So beforehand, this is the patient standing on their $800 custom-made orthotic that was not helping them whatsoever. Okay, so that's why now they're standing on their foot without the orthotic, and you can see that we've reduced this deformity. So it's pretty cool. So again, here we have a before and after. We see this partial dislocation of the talus on the calcaneus, and this is a before and after. So patient had a previous bunion surgery, and she presented to have a revision. They're like, I had bunion surgery a couple years ago, and it's already back. So instead of performing another revision bunion surgery correction, the only thing that she had done was the insertion, this is the hindfoot, the insertion of HyProCure. So let's take a look at what happened. So yes, we still have this soft tissue thickening, and this post-op, this is a full weight-bearing fluoroscopy that was about 2 to 3 weeks post-op. So we look at the sesamoid position pre-op, and we see that just by putting in HyProCure, we've reduced the inner metatarsal angle significantly. And then we take a look at the overlap between the hallux and the second toe, and that there's significant straightening of the hallux, again, without performing any other surgery. So that's why it is important that we address the hindfoot first before we go in and do this forefoot surgery. But let's not get carried away, because when they have this severe deformity, don't think that you're just going to put in a HyProCure and that something this severe is going to reduce. Obviously not. But you put in HyProCure, stabilize the hindfoot, and then you go in and attack the first ray and hallux and rebalance that. And now what you'll see is that the patients are going to have a significantly improved long-term prognosis versus the traditional way of how we would fix things. So, again, some people say, well, I perform this kickstand procedure where I do a lapidus and then that realigns the hindfoot. No, there's no evidence for that. What happens is the talus is still partially dislocated, and we have excessive motion happening on the medial column of foot bones, because when the heel lifts up, the bones are locked, and right before toe off, we have all of that force pushing up on the first metatarsal bone. So all of that force is going to now take place back here between the medial intermediate cuneiform joint and between the first and second metatarsal bases, and then back here between the navicular and the medial cuneiform. So that creates this diastasis over here, and we still have a problem. Or we wonder why patients develop, and again, this is not a very common finding, but this is something that happens. Why did they fracture their bones and have this horrible reaction over here? Well, that's because nobody addressed the underlying etiology. So we don't want that to happen. So we recommend this as a staged procedure. When somebody comes in for that bunion consultation, we always say to put in HyProCure first, and then you address the first ray as a secondary surgery at a later date. Now, this is not because we were trying to perform as many surgeries on this patient spread out over the rest of their life. The reason why we do this is for the benefit of the patient, because what happens when you have hindfoot surgery, and I don't care what it is, your body naturally is going to guard the lateral aspect of your hindfoot, and it's going to force your muscles to supinate the hindfoot to try to reduce pressure while the soft tissues are healed because of the inflammation during the recovery process. So when you put in a HyProCure, you're going to have an over-supination that's going to happen in the hindfoot, and then when you perform first MPJ surgery at the same time, you're going to have that secondary guarding of your first MPJ. So now you have a hindfoot and forefoot supination, and the patient's going to walk really crazy for a while until the inflammation and pain subsides. So when you put in the HyProCure first and you allow the body to heal from that, and then you also can see if you even need to do a first-rate procedure or not, but that way the patient's going to have a better recovery. It'll be a faster recovery with less complications, because when they start guarding their hindfoot and forefoot, it's going to take a while for that to go away. So when we take a look at a mission accomplished, what is the best scenario for our patient? Well, again, sums it all up right here. And this is our last slide during this webinar, is that we fixed both of the deformities. We've realigned and stabilized the talus on the calcaneus. We've reduced and while achieving a natural range of motion between the hindfoot bones with an effective, scientifically proven method versus custom-made orthotics. And we have normalized the first metatarsal under the sesamoids, and we've reestablished the stability of the forefoot. And so anyway, I think that this is the correct way that we should be approaching this, and it's the best for our patients. So thank you very much. That's the presentation that I have for you here.